Hello, my name is Dr. Amy Pollack. I'm a cardiologist at the Mayo Clinic in Jacksonville, and I'm looking forward to talking with you today about vascular lab testing. I don't have any disclosures, and this talk is really a prelude to the CVBR talk on peripheral artery disease. So we'll talk today about how an ABI, or ankle-brachial index, is interpreted, and then look closely at what other information we can get from a vascular lab report, specifically looking at segmental pressures, at the pulse volume recording or PVR waveforms, as well as the arterial Doppler waveforms. So we'll first look at that ankle-brachial index. And when we think about peripheral artery disease, it certainly is a broader umbrella term, but for the purposes of today, we're really just focusing on lower extremity peripheral artery disease, or PAD. And PAD can certainly be non-atherosclerotic, but generally is atherosclerotic in origin, and patients present with stable exertional symptoms, which we classically think of as involving claudication, chronic limb ischemia, or acute limb ischemia. And ABI testing is absolutely part of that initial testing for claudication and chronic limb ischemia. So we'll just start with a brief patient case. A 74-year-old woman who has diabetes, hypertension, and dyslipidemia presented with lower extremity fatigue with exertion. She wasn't having leg pain per se, but legs just felt very tired. She did have some burning discomfort in her legs at rest that did worsen with exertion. She had to use a walker for walking distance, and on physical exam, she had decreased pedal pulses. And so with that decreased pedal pulses and risk factors for PAD, we wanted to do ABI testing. So how is that ABI testing done? Well, you have patients lay on an exam table, and then you're using a small ultrasound device and a blood pressure cuff to inflate the blood pressure cuff up to be able to identify where you're hearing that highest systolic pressure, both in the ankle as well as in the arm or the brachial. And we're looking both at the posterior tibial as well as the dorsalis pedis. And importantly, and this is a very testable topic for the boards, you need to be checking the blood pressure, systolic blood pressure in the right arm and the left arm. And whichever one is higher of the two arms, you're going to use that in the ABI equation for either leg. So you can have the right ankle blood pressure over the left arm pressure if that's the higher blood pressure between the left and the right arm. So an important concept, very testable on the boards. And keep in mind that we're using the higher of the pressures in the ankle. So whichever one is higher, DP or PT. If we were to use the lower pressure, we're certainly going to then expand our sensitivity for the diagnosis of PAD. We're going to be diagnosing more patients with PAD, but we lose some of that specificity. And that's where the consensus is to use the higher blood pressure at the ankle with whichever blood pressure in the arm is highest. And a normal ABI is going to be between 1 to 1.4. Abnormal is going to be 0.9 or less. And then you'll see you have this borderline category here, 0.91 to 0.99. And we'll talk in the CVBR talk on PAD, more specifically about the role of exercise testing, where you have somebody walk on a treadmill or do calf raises and then recheck the ABI, particularly for that borderline category. I also want to highlight for this ABI that's quite high, greater than 1.4, these are non-compressible vessels. And oftentimes there is atherosclerosis or calcification there. And so the toe brachial index, if we're measuring that Doppler systolic pressure down at the toe, that is not going to be as affected by calcification in vessels. And so you still can look at a toe brachial index. If it's less than 0.7, that is considered abnormal. So we get that the ABI value on the vascular lab report, but what other information do we get? Well, we get information about segmental pressures. And so that's really going to be that systolic pressure, that arterial closing and opening pressure. And we're looking for a drop of 15 to 20 millimeters of mercury between different levels, where those blood pressure cuffs are up and down the legs. And that would be a sign of a pressure limiting stenosis. So on this vascular lab report, we're going to be looking at essentially each of these blue circles are where the evaluation or Doppler testing was done. And we can look here for that segmental pressure difference. So that systolic pressure here in the right femoral of 143. Then as we're getting down to the popliteal of 127, and then the posterior tibial 143 and dorsalis pedis of 142. So we can get information about those segmental pressures to help localize where there may be a significant stenosis between femoral, popliteal, and tibial. Well, what else do we get on the vascular lab reports? We have the PVR waveforms, or the pulse volume recording. So this is measuring a volume and flow pattern. So you're inflating the blood pressure cuff, and it's usually to about 60 millimeters of mercury. And then that arterial inflow that going through the vessels is going to displace the air in the cuff. And that increase in pressure is something that we're going to be able to measure. And this is, generally speaking, independent of arterial calcification. So even if you had non-compressible vessels with an ABI of 1.4, 1.5, you can still get information about the health of the vessels from the PVR waveforms. So what do those waveforms look like? So normal, you should have a triphasic waveform where you get this rapid upstroke, a dichrotic notch, and then a rapid downstroke. An abnormal pulse volume recording is going to be more of a biphasic pattern where you don't have quite as high of a peak, so it's going to peak lower. You're going to have it potentially with not as quick of an upslope, so it's going to look more like a mound, and then you lose that dichrotic notch. And then monophasic is going to be representative of more severe disease when you really get more of this sinusoidal waveform, or even starting to be more of a nearly flat line. So the key is that a normal PVR waveform should be triphasic, rapid upstroke, dichrotic notch, and a rapid downstroke. And we'll see an example of an abnormal PVR in just a moment. In a similar way, for some vascular labs, you will, instead of having the PVR waveforms, you'll have a leg arterial Doppler waveform reported on that vascular lab. And this is a continuous wave Doppler. You again are looking for a triphasic appearance where you get that sharp upstroke, this peak systolic component here in blue. Then you get an early diastolic flow reversal. And then you get this late diastolic forward flow here in red. So this would be a normal arterial leg Doppler waveform with that triphasic sharp upstroke, peak systolic component, this in the purple, the early diastolic flow reversal, and then late diastolic forward flow. So this is a good mental image to have for what that normal triphasic arterial leg Doppler waveform looks like. So this is an example of a vascular lab report with that arterial Doppler waveforms. Again, this is not the PVR, this is the arterial Doppler waveforms. We can see here in the femoral artery, we've got a nice normal triphasic, a rapid upstroke, we've got that rapid downstroke and the reversal that happens in late diastole. If you start to have evidence of disease with the arterial Doppler, we lose that diastolic forward flow. And so you get more of a biphasic pattern. And then monophasic is when you lose that flow reversal and you get more of that sinusoidal waveform. So if we look back to our patient for that vascular lab report, you can see that here she has more of this, this biphasic appearance in the femoral arteries. So we don't have that really rapid upstroke. We've lost that dichrotic notch. And so this is not a triphasic appearance, but is more of a biphasic. So this is a PVR waveform. And you can see that as she's getting down to the dorsalis pedis, I think it's easier to see on that left side, it's becoming more sinusoidal. We're not having as much of a difference in height of that waveform. And we can see that not only are her PVR waveforms abnormal, but she has an abnormal ABI on both sides of 0.60 and 0.61. And if we're looking at her segmental pressures, from her upper thigh at the femoral, segmental pressure was 142, and then down at the popliteal dropped to 116. So that certainly is a significant drop in blood pressure concerning for an area of stenosis. And she had had multifocal disease. She'd had really pretty significant iliac disease on both sides. And with ultrasound, you can measure flow, and had quite high flow in both the iliac arteries at 2.76 centimeters per second on the right, and on the left, 2.92 centimeters per second. And you can see after stenting, she had certainly visually an improvement in the appearance of her bilateral iliac arteries. So this is just meant to be kind of an intro to vascular lab reporting. It involves more than just the ABI. We can have that toe brachial index, segmental blood pressures, the pulse volume recordings, and that Doppler waveform. And I think for the purposes of what you would need to know for the boards, I highlighted the normal images when we were going over what PVR looks like or what the arterial Doppler looks like, because I think that's the most important part to cement in your mind. If you can have clarity of what that normal triphasic waveform looks like, then it's not, I think, as critical for the purposes of the general cardiology boards to be able to determine, is this a biphasic or monophasic, but more, is this normal or abnormal on the vascular lab testing? And certainly the ABI, knowing how to calculate that and what's a normal versus abnormal ABI, including that heavily calcified vessels with the non-compressible more than 1.4, those are also very testable topics for the boards. So with that, I'll thank you very much.